so excited that we are having it now and that you're all here, because it feels to me like we're finally really moving from talking about changing things to doing some things that change things. It's not just DSRIP. There's a lot of pressures on the healthcare system that are accelerating change, and we know that complexity is going to be increasing over the next years, and how providers of healthcare get paid is going to change quite a bit. But I think one thing that's really very clear is that better care coordination is necessary for better outcomes for patients.
Care coordination in the medical neighborhood. What this means is working at a local level with providers who work with each other on a day-to-day basis, share patients, and actually engage in the care transitions process.
So the scope of work for our care manager, she's in the hospital, she is an RN again, she is a certified case manager. So she really is doing that case management, real psychosocial stuff as well as the nursing component. Not hands-on nursing, but the clinical component of assessment, et cetera. She is in the hospital. She works directly with the care transitions team and has developed a very nice relationship with them, actually. She really appreciates their teamwork there. She is referred patients who score moderate to high risk for readmission, and that's based off of the hospital assessment tool. They're using LACE currently.
I raise my hat to you guys. We have accomplished a lot. Actually, I was getting very jealous. I was getting jealous, and then I was saying, wait a minute, they only have one hospital, we have 7 hospitals that our patients go to, and there's no way to track these people. So I'm hoping this will be an opportunity for me to ask the district people to help us get some care coordinators who can coordinate this thing. So
but I think what's really working well is that we finally have the patients connected to the right providers, and it's not controlled at the inpatient level at the point of discharge, and transitions of care in the inpatient area is not managing patients that they shouldn't be managing.
We are making a lot of relationships. We know that there are some large groups, there are some private physicians' offices that have care navigators, and we've connected with them.
Narrative medicine is the clinical and scholarly endeavor to honor the central role of stories in healthcare. We define structural competency as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases also represent the downstream implications of upstream decisions. The idea that Muslim women perhaps need saving has been, in fact, the motivation behind lots of military action, right? Again, this is not to say that domestic violence doesn't happen in many communities. This is not to say that suffering does not happen in any communities. Is it ubiquitous? Is it the overall value of any entire community? Of course it isn't.
That maybe an unintended consequence of these is that they're creating unconscious bias.
I'm going to talk about a different kind of pedagogy which uses their experience so that they can assimilate the information and connect it to something. So I wanted to say that about asset-based and empowerment. We do not empower our clients or our patients. What we do is we provide them with the skills and the tools to empower themselves.
And one of our psychologists, Dr. Naomi Pearl, has been counseling patients with diabetes. She's now counseled, I believe it's close to 50 patients with diabetes. And that cohort had an A1C on average go from 9.6 down to about 8.2 over 3 months.
And my mother was 38. And then from 38 through her 60s, she went through all of these stages. And she tried to start taking care of herself in her mid-60s, and she lasted for a while. But it was classic. It was really classic.
People need to be very attuned to their bodies, and
And what this entails is knowing prior to diabetes, when did you get sick? Did you get sick?
A tremendous amount of work and focus has gone in. I am so deeply grateful to each and every one of you and to all of our speakers here today. And who knows what we will be discussing this time next year.